Okay, my name is Frances Hammer, and this is my video for the head to toe assessment. The first thing that I would do is check and make sure that I have the patient's name and date of birth. I would go into the room and greet the patient, perform hand hygiene. Um, I'd check the patient's wristband and make sure that I have all the information correct. I would explain the procedure to the patient and give them a timeline of how long it was going to take. I would observe the environment to make sure that the patient stays safe. I would look for any IVs, drains, anything that I might be able to trip over. Go away, John. Um, I would then, while talking to the patient, I would observe them and note their appearance, their general appearance. I would note their speech. I would note the level of consciousness, ask them questions about where they are and if they know who they are and the date and the time, and make sure that they know what is going on, to evaluate the level of consciousness. Um, I would, after speaking with them and registering how they're feeling and their well being, I would move on to the assessment. Um, I would perform the assessment one area at a time and only exposing the area of skin that I needed at that moment rather than exposing the entire patient's body. So I would provide them modesty and make sure that the room was private, the door was closed, the curtain was closed, um, and that the patient was comfortable. Um, so to begin my head to toe assessment, I would want to start with the patient's head and neck. So this is my patient. I would want to look at, with my pen light, I would want to look at the ears and while looking at the face, make sure that the ears are symmetrical, that they are in the same place. The placement is symmetrical. I would look at the outer ear and make sure that there weren't any lesions or wounds. If there were any, I would note those and make sure to document it in the chart. I would look at the color of the skin, the temperature, and make sure that everything is normal. And if there was anything that was not normal, I would make sure to document that as well. I would look at the ear by pulling the pinna back and up, and I would look inside of the ear, noting any earwax or any lesions or bumps or anything like that that might be inside of the ear. I would do that on both sides, respectively. I would also perform the whisper test, where I would get behind the patient and speaking into one ear, have them repeat what I said without having them see me. I would then go to the other side and perform the same test on that side. I would also look at the hair and the scalp, making sure to palpate and find if there are any bumps or tender areas, making sure to note any lesions or anything like that, checking to make sure that the hair is clean, that the patient is healthy, and noting any abnormalities that I might find. I would then look at the, let's see, head, ears. I would then look at the eyes and make sure to note the eyelids and make sure that they are the same, that the eyes are placed symmetrically, and that they're equal distance apart. I would check to make sure that the eyelids are the same, check to make sure that the conjunctiva is pink and moist like it should be. I would check for any drainage out of the eyes, any drooping of the eyelids, any abnormalities as far as if the eye is drooping or not opening as much as the other eye. I would then look at the pupils themselves using my pen light. I would take the light and shine it into the eye and make sure that the pupils are equal, that they're reacting to light, and make sure that everything is going the same way that it should. I would do the same thing on the other side, making sure that the eye is reacting to light, and checking to make sure that there wasn't any abnormalities. The next step that I would do is to check for accommodation, where I would hold my pen light 4 to 6 inches away from the patient's face, and then I would have them look at the pen light and then look at something in the distance and then look at the pen light and make sure that everything is doing what it's supposed to, that they can see everything. The next thing that I would do is check for not accommodation. I would check for convergence, where I would hold the pen away, bring it towards the patient's nose, and make sure that the eyes do indeed cross. I would check for extraocular movements with the cardinal positions. So I would have the patient follow the pen light from the top to the nose and then down and over, and do the same up here and up and down, and make sure that they keep their head still, and but follow the movement with their eyes. Next, I would check the patient's nose. I would look at the exterior of the nose and check and see if I saw any deviation, any bumps, or if it was pushed to the side. Either way, I would then check the patency. So I would use my pen light to look into the nostril and make sure that there weren't any lesions or bumps inside the nostril. I would check the septum also to make sure that the septum was not deviated to the left or the right, that it was midline. I would, before I started evaluating the nose, I would have the patient blow their nose. I would then go and evaluate the other side of the nose, doing the same thing, looking at the mucous membranes, making sure that they are pink and moist, and that they are working the way that they're supposed to be. The next part that I would do is to palpate the sinuses right above the patient's eyebrows. I would push on the sinuses to see if there's any pain. I would also do the cheeks. Then I would palpate the sinuses. I would check to see if or no, this is, I would check for the nerves. I would puff out my cheeks and have the patient do the same thing. I would wrinkle my forehead. I would smile and just have them repeat the same movements that I do, and frown. Then we would I would check for soft touch, taking the edge of a glove and rubbing it against their face to make sure that they could feel it, and noting where it was. I would then look at their jaw and their mouth. I would have them open their mouth, and I would look inside their mouth for any lesions or abnormalities. I would look at the mucous membranes to make sure that they are moist and pink. I would have them open their mouth and say ah, and look at the soft palate and make sure everything's working the way that it's supposed to do. I would have them stick out their tongue, and then I would also have them take their tongue and push it into their one cheek and then push it into the other cheek. I would have them, while I had my hands on their face, I would have them open and clench their jaw to check for the jaw muscles and make sure that everything is working the way that it's supposed to be working. Then I would check for the range of motion. I would have them turn their head from midline to one side and then back, and the other side and then back, and then head or the ear to their shoulder, and the same thing on the other side. I would have them put their head back and check their trachea for alignment, make sure that it is midline and straight. I would palpate one at a time the veins, and then I would listen for a bruit in the I would listen for bruit. What am I forgetting? I would put my hands on the patient's shoulders and have them raise their shoulders against my hands while I push down. I would then put my hand on their cheek and have them, while I'm pushing against their cheek, push back against my hand on both sides. Let's see, eyes, nose, mouth, cheek, neck. while examining all of their face, neck, their whole body, I would be checking the skin color, temperature, making sure that there aren't any abnormalities and noting all of the abnormalities. While having the patient sit, I would examine their thorax for color, shape, contour, and symmetry. I would auscultate breath sounds. I gotta put my patient down. I would auscultate breath sounds with from one side to the other in a ladder position, all the way from the apex to the base, back and forth, having them take a deep breath with each movement of the stethoscope. I would then what would I do next? Then I would put my hands on their back and check for any vibrations, and I would have them say 99, and I would move my hands down the back. I would also put my hands on the patient's back like this and have them take a deep breath in and watch how my hands move. Make sure that they are moving symmetrically and that everything is working the way that it should be. I would also palpate for tenderness. Very carefully, checking for any areas or abnormalities under the skin, and noting all of those to make sure that I document everything at the end. I would note the number of pillows that the patient uses when they sleep. And with them sitting, I would auscultate the heart sounds. So I would do it with the diaphragm, starting on the with the aortic. I would go aortic, pulmonic, Erb's point, tricuspid, and the mitral valve. I would listen to the apical pulse on the in the fifth intercostal space, what's the word? The fifth intercostal space, in line with the middle of the sternum, underneath the nipple. I would listen for a full minute and note the rate, rhythm, S1, S2, all of the heart sounds. After that, I would have the patient lay down, and I would look at their belly. I would want to check for any deformities, any distension, making sure that everything is symmetrical, and just looking at the patient's belly, and making sure that everything is the way that it should be. Then I would listen for bowel sounds, and I would do that with the diaphragm, and I would start in the right lower quadrant. Then I would go to the right upper quadrant, the left upper quadrant, and the left lower quadrant. I would then flip my stethoscope around and listen with the bell, doing the same thing. The right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. If there were any areas of pain or tenderness, I would listen to those areas last. With the bell of the stethoscope, I would also listen for an abdominal bruit. And then I would listen for bowel sounds. I would note the frequency, and if I didn't hear any bowel sounds after a minute, then I would listen for 2 minutes or a max of 5 minutes for the abdomen. While I have the patient laying down, I would also palpate the bladder to see if there's any bladder distension. After that, I would palpate all 4 quadrants for tenderness or guarding, using the pads of the fingers in a rocking motion. I would palpate the belly, checking for rebound tenderness, organ placement, any lumps or bumps, any abnormalities. I would also be checking to see if the belly is soft and non-distended. Then I would start examining the upper extremities, with the patient sitting. I would look at the condition of the nails and hands. I would palpate for temperature, moisture, texture. I would also check the radial pulse on both arms and the brachial pulse as well on both arms. I would check the capillary refill by pushing on the patient's fingernail and releasing, and seeing how quickly the color comes back to the fingers. After that, I would check the range of motion. With the range of motion, I would have them flex the upper arm, and they would lift their arm up while I am pushing their arm down. I would do that on both arms, checking for stiffness or limited range of motion. I would also have the patient, oh, you can't see. I would have the patient bend and straighten the elbow, the wrists, and the hands to make sure that everything is moving the way that it's supposed to be moving. I would test the grip strength by giving the patient 2 fingers and having them squeeze both of my hands with their hands at the same time, and making sure that the muscle strength in both hands is symmetrical on both sides. I would also check the hands and arms for any edema and note that if it is present. The last thing that I would check for is the lower extremities. I would watch how the patient ambulates and moves, marking any how they get out of bed, how they move by themselves, if they use any assistive devices. I'd inspect the condition of the skin on the legs and the nails on their toes. I would check the temperature of the skin. While I was on the chest, I would check turgor on the collarbone by pinching the skin and seeing how quickly it goes back. To check for dehydration. What do we check for? I would check capillary refill on the toes by pushing on the toes and letting go, just like I did with the fingers. If it's under 3 seconds, then their circulation is good. I would check for leg strength by having the patient raise the leg up while I push down. I would also have them move their leg from the middle out and to raise the thigh against counter pressure. This would all be done with the patient sitting. I would do the same thing with their feet, having them try to raise their feet up, their toes up, against resistance. So while I push down on the tops of their feet, they would be trying to raise their toes up. I would check light sensation with the tip of a glove or a cotton ball and have them close their eyes and tell me where they feel the cotton ball or the glove. I would look at any inconsistencies in the skin. I would look for any lesions or injuries, any difference between the symmetry of the muscles or the movement of the legs. I would then have them point their toes and make sure that everything is moving the way that it should be moving. The last thing that I would check for is the Babinski reflex. I would run my pen light or a pen up the patient's foot, and if they spread their toes, oh God, gosh, is it spread their toes or clench their toes? I can't remember. But I would have them excuse me. Yeah, I would check for the Babinski reflex on both feet. Well, I have the patient standing, I would check their spine for any deformities. I would check their balance, their coordination, and their gait. When I'm looking at their legs, I would be looking for any edema. I would check their ankles and their feet for edema, since those are the most frequent places where the edema shows up. And once I finished my evaluation, I would document all of my findings. I would also, while I was looking at the feet, I would check for pedal pulses in both feet. And if I could not find the pedal pulse, I could use a Doppler to find it. Excuse me. Yeah. When I was finished with my assessment, I would thank the patient. I would lower the bed to the lowest setting, make sure that the side rails are up, that all of the patient's personal belongings are within reach, that they have the remote and the call light within reach, and see if they need anything before I leave the room. I would also perform hand hygiene before I leave the room. And that's everything.